Welcome to the Deep Dive, where we really try to cut through the noise and bring you the insights that matter. Today, we're tackling a really important topic, one that affects millions: breast cancer. And just to set the scene, here's a striking fact. It's the most common cancer globally, and right here in the US, we're talking nearly 4 million women affected in America alone. That number feels huge, honestly. But, and this is crucial, there's real reason for hope. Survival rates are actually climbing quite steadily.
They absolutely are. And, that progress isn't just luck. It's really down to amazing advancements in how we detect it early and how we tailor treatments much more personally now. It's really changed the game.
That's such a key point, and it really frames what we want to do in this deep dive. We're going to try and untangle the complexities of breast cancer for you. We'll look at what it actually is, the early signs you really need to know, who might be more at risk, and, well, the whole journey, right? From getting diagnosed to the treatment itself. Our aim is simple. Cut through the overload, give you that clear, impactful knowledge so you understand just how much early action and that personalized care can change things.
Yeah, get ready for maybe a few aha moments. We're here to guide you through all the details, hopefully with clarity, maybe some surprising facts along the way, and just focus on what's really vital so you feel informed, maybe more confident about this critical health topic.
Okay, let's dive in then. When we say breast cancer, what's actually happening inside the body? At the cellular level, what is it?
Right. So at its most basic level, breast cancer starts when some cells in the breast tissue, well, they start to mutate, they change, and they start growing completely out of control. Instead of following the normal cell life cycle and dying off, these abnormal cells just keep multiplying, and eventually they form a lump, or what we call a tumor.
And it's not just one thing, is it? I mean, I've heard there are different kinds, and where it actually begins makes a big difference. Can you break that down for us?
Absolutely. That's a common misconception, that it's all the same. But where it starts and how it behaves, massively important. So we mainly group them by where they originate. You've got ductal breast cancer, which starts in the cells lining the milk ducts. Those are the main pathways. Then there's lobular breast cancer, starting in the lobules, the glands that make milk. Ductal is definitely the one we see most often, by far.
Okay, so location is key. What about how it spreads, or if it spreads? Because that feels like the really critical difference in terms of how serious it is.
It is the critical difference.
Yeah.
We talk about non-invasive versus invasive cancer. Think of it like the breast tissue has these natural barriers, okay, like walls. In non-invasive cancer, often called ductal carcinoma, in situ, or DCIS, the cancer cells are still stuck inside those ducts or lobules. They haven't broken through the wall. So usually they don't spread.
Right, so it's contained, like you said, inside the walls.
Exactly. But invasive cancer, and this is about 8 out of 10 cases, often invasive ductal carcinoma, that means those cells have broken through that wall, that protective layer we call the basement membrane. Once they're through, they can potentially move into other parts of the breast, or get into the nearby lymph nodes, or even travel to distant parts of the body.
And that potential spread, that's metastasis, right? That's where the real danger ramps up significantly.
Unfortunately, yes. It typically spreads first to nearby lymph nodes. The ones under the arm or maybe around the collarbone. These little glands act like filters. But if the cancer cells get past those nodes and reach other organs, we're talking bones, liver, lungs, brain, that's when it's called metastatic breast cancer. And at that stage, it's considered incurable, which just highlights again why catching it early is so important. The focus then shifts completely to managing it, controlling it, maintaining quality of life.
That really drives home the urgency. So if early detection is everything, what are the absolute key warning signs? The things you should be looking out for in your own body? What are those flags?
Yeah, it really boils down to knowing your own body and noticing anything that's just not normal for you. Now, a new lump or thickening in the breast or armpit, that's the most common sign, sure. But here's something important. About 1 in 6 women diagnosed don't actually have a lump.
Wow, 1 in 6. That's surprising.
It is. So beyond a lump, you need to watch for other things, like discharge from the nipple if you're not pregnant or breastfeeding. Dimpling on the breast skin, sometimes it can look a bit like the skin of an orange. Nipple changes are another big one if it starts turning inward or pulls to one side, or if the skin on or around it gets scaly or changes texture. And also just general irritation of the skin puckering, redness, maybe a rash that just won't go away on the breast.
So it's definitely not always that obvious lump. Are there other, maybe more subtle things to be aware of?
Absolutely. Any kind of unexplained change in the size or the shape, or even just the overall feel of your breast, if something feels different and it persists, pay attention.
Right, and it's so important to add, our bodies change all the time. Not every single change means cancer, does it?
Exactly. Most changes, especially related to your cycle, are totally normal hormonal shifts. Nothing to panic about. But here's the crucial takeaway for you listening. These symptoms, they might look different depending on your skin tone, and they could be caused by something else entirely. The bottom line is, if you notice any of these signs, or really any change that isn't normal for you, please go see your doctor. Even if it seems minor, get it checked. Better safe than sorry.
That's really solid advice. Okay, let's shift gears slightly and talk about risk. Who is actually more likely to get breast cancer? How do we understand our own risk factors, things we can't change, versus maybe the things we can?
Understanding your personal risk is, well, it's empowering, right? Let's start with the factors you can't control, the non-modifiable ones. Age is a big one. Your risk definitely goes up as you get older. About 77% of diagnoses are in women over 50. It's very rare, less than 1% in your 20s. Gender, obviously, is the biggest risk factor. Being female puts you at much higher risk, although it's important to remember men can get breast cancer too. It's about 1% of all cases.
And what about family links? Genetics? That always seems like such a strong factor in people's minds.
It really is. Family history is critical. If a close relative, think mother, sister, daughter, had breast cancer, your risk roughly doubles. If 2 close relatives had it, your risk can jump 5 times higher, and often this points towards genetics. Specifically, mutations in certain genes, most famously BRCA1 and BRCA2. These mutations significantly increase the risk for both breast and ovarian cancer. There are others too, like TP53 and PTEN mutations.
Wow.
Yeah. Then there's hormonal exposure over your lifetime. Starting periods before age 12 or going through menopause after 55 means your breast tissue is exposed to estrogen for longer, which slightly increases risk. Also, a personal history of breast cancer means a higher risk of it coming back. And finally, significant radiation exposure to the chest area, maybe from earlier treatments for other conditions. That's another factor you can't change.
Okay, that's a lot we can't control, but what about the factors we can potentially influence? Where can we take action?
Right, these are the modifiable risks where you have some control. Alcohol is a clear one. Studies show that having 2 to 5 alcoholic drinks per day raises your risk by about 1.5 times compared to women who don't drink. So limiting alcohol is definitely key. Weight is another significant one. Being overweight or obese, especially after menopause, increases estrogen levels in the body, raising risk. So maintaining a healthy weight through diet and exercise is really important.
Okay.
Hormone replacement therapy, or HRT, used for menopause symptoms, particularly long-term use of combined estrogen and progestin, has been linked to increased risk. That's a conversation to have carefully with your doctor about risks versus benefits. And lastly, childbearing. Having your first child after age 30 or never having children can slightly increase risk. Interestingly, breastfeeding seems to potentially reduce risk later on.
That paints a much clearer picture of the risk landscape. Okay, knowing all that, let's walk through what happens when someone actually finds something concerning. Let's use that case study from our sources to tie it all together. We have a 52-year-old postmenopausal woman. She found a new lump herself during a self-exam about 2 weeks ago. She describes it as firm, doesn't hurt, it's in her right breast. She also noticed some mild nipple retraction, and her bra feels tighter on that side, and her family history is significant. Her mother had breast cancer at 45, and aunt had ovarian cancer at 50.
Okay, yeah. This patient's situation immediately sets off several alerts. The new lump, the nipple change, and especially that strong family history of both breast and ovarian cancer at relatively young ages. That combination makes you think immediately about potential genetic links, like BRCA mutations.
So with those flags raised, what's the immediate next step for imaging? How do doctors decide what tests to order first?
Right, this is where we move from routine screening into diagnostic mode. Because she has symptoms, we need to investigate specifically. Now, if a patient is under 30 and finds a lump, we usually start with a breast ultrasound first, mainly because younger women tend to have denser breast tissue, which can make mammograms harder to read. But for someone 30 or older, like our 52-year-old patient here, the standard guideline is to start with a diagnostic mammogram. And that's typically followed up immediately with a targeted breast ultrasound focused right on the area of concern. Using both gives a really detailed view.
And in her case, what did those images actually show about the lump?
Her imaging revealed what radiologists would call highly suspicious features. The mammogram likely showed a speculated mass. That means it has sort of spiky edges, maybe with tiny calcium deposits called microcalcifications. The ultrasound then probably showed what's called a hypoechoic irregular mass, basically a dark, oddly shaped area. These findings together are strong indicators that it could be cancerous.
I've heard people mention a BI or DES score. What exactly is that, and why is it so important for what happens next?
Yes. BIREADS. It stands for Breast Imaging Reporting and Data System. It's basically a standardized way for radiologists to categorize the findings on mammograms, ultrasounds, or MRIs. The score goes from 0 to 6. A score of 1 or 2 is generally normal or benign. 3 is probably benign but needs short-term follow-up.
Yeah.
But a score of 4 or 5, which our findings would almost certainly generate, means the finding is suspicious or highly suggestive of malignancy. 5. And that score absolutely means a biopsy is the necessary next step.
Okay, so the biopsy is really the definitive test.
It's the gold standard, yes. A core needle biopsy is typically what's done. They use a slightly larger hollow needle to take several small tissue samples directly from the suspicious mass. Those samples go to a pathologist who looks at them under a microscope. That's how you get the definitive yes or no on cancer, and importantly, what type of cancer it is. Fine needle aspiration using a thinner needle is sometimes used, but more often for draining cysts rather than diagnosing solid lumps.
Right, so the core needle biopsy gives the real answers. And her pathology report came back confirming invasive ductal carcinoma, the most common invasive type, you said. But critically, it also mentions specific markers, ERPR positive and HER2 negative. Why is knowing those markers so incredibly vital?
This information is. It's everything for planning treatment. It's where cancer care becomes really personalized. Think of these markers like signals on the surface of the cancer cells. ERPR positive means the cancer cells have receptors for the hormones estrogen, ER, and progesterone, PR. Basically, these hormones act like fuel, telling the cancer cells to grow.
Okay.
Knowing this is actually often good news, relatively speaking, because it means we have very effective anti-hormone therapies that can block that fuel supply. HER2 negative means the cancer cells don't have an overabundance of another protein called HER2, which is involved in cell growth. So treatments specifically targeting HER2 probably won't work for her, which helps narrow down the options. These markers essentially give us the instructions for how to best attack her specific cancer.
That makes sense. It dictates the strategy. So with this confirmation and these marker details, how do doctors figure out the cancer stage and map out the overall treatment plan?
Right. Staging is the next critical step. It tells us how extensive the cancer is. First, we need to assess if it's spread to lymph nodes. Her physical exam noted a lymph node under her right arm axillary node that felt a bit enlarged, about 1.5 centimeters, but it was mobile and not tender. Mobile is generally a bit better than fixed and hard, but it definitely needs checking. So during surgery, they'll perform a sentinel lymph node biopsy. This is a really clever technique where they identify and remove just the first 1 or 2 lymph nodes that drain the tumor area, the sentinels. If those are clear, it's unlikely the cancer has spread further through the lymph system, and they can avoid removing more nodes unnecessarily, which reduces the risk of side effects like lymphedema. In our patient's case, the biopsy confirmed that 2 of her sentinel nodes were suspicious, meaning they likely contain cancer cells.
Okay, so node involvement is confirmed. What about checking for spread elsewhere in the body, like the lungs or bones? Do they do full body scans on everyone?
Generally, no, not unless the patient has specific symptoms suggesting distant spread. Things like a persistent cough, shortness of breath, significant bone pain, abdominal pain, or neurological symptoms like bad headaches or vision changes. If there are no such symptoms, guidelines usually don't recommend doing extensive scans like PET scans or CT scans right away for early-stage breast cancer, like hers seems to be. It avoids unnecessary tests and anxiety. And thankfully, our patient had no signs of distant metastases.
Okay, good. So we have the tumor information, the node information, and no distant spread. How does that translate into the formal stage using that TNM system you mentioned?
Right, the TNM system. T is for tumor size, N is for node involvement, M is for metastasis. T, tumor size. Her tumor was 3 centimeters. T1 is usually 2 centimeters less. T2 is between 2 and 5 centimeters. T3 is over 5 centimeters. So 3 centimeter tumor makes her T2N, node involvement. She had cancer cells found in 1 or 2 axillary lymph nodes, and they were mobile. That typically corresponds to N1. N0 would be no nodes involved. M, metastasis. We know she has no distant spread, so she's M0. M1 would mean distant metastasis.
So putting it all together, T2, N1, M0, what overall stage does that place her in?
T2, N1, M0 corresponds to stage 2A breast cancer.
Stage 2, okay. Now we have the full picture. Stage 2A, invasive ductal carcinoma, ERPR positive, HER2 negative. What does the tailored treatment plan look like for her?
For stage 2A with those characteristics, it's usually a combination approach, very much tailored. First, surgery. Most likely a lumpectomy, where they remove the tumor itself, plus a small margin of healthy tissue around it combined with that sentinel lymph node biopsy we discussed. Sometimes a mastectomy might be considered, but lumpectomy is often feasible for T2 tumors. After surgery comes radiation therapy to the remaining breast tissue. This is crucial after lumpectomy to kill off any microscopic cancer cells that might be left behind and significantly reduce the risk of the cancer coming back in that breast.
Okay.
Then, because her cancer is ER/PR positive, anti-hormone therapy is absolutely key. Since she's postmenopausal, the standard treatment would be an aromatase inhibitor. These drugs work by drastically lowering the amount of estrogen in her body, effectively cutting off the fuel supply to any remaining cancer cells. She'd likely take this for 5, maybe even 10 years. For premenopausal women with ER/PR positive cancer, the drug tamoxifen is often used instead, or sometimes ovarian suppression plus an aromatase inhibitor.
Right, and what about chemotherapy? Is that always necessary for stage 2A?
Not necessarily, and this is a great example of how personalized things have become. For ER/PR positive, HER2 negative cancers, especially with limited node involvement like hers, the decision often hinges on a genomic test performed on the tumor tissue itself. Tests like the Oncotype DX score, or others like MammaPrint, analyze a panel of genes within the tumor to predict the risk of recurrence, and importantly, how likely the cancer is to respond to chemotherapy. If the score comes back low, indicating low risk and low potential benefit from chemo, she might safely skip it, avoiding the significant side effects. If the score is high, then adjuvant chemotherapy would likely be recommended. Common chemo drugs used might include doxorubicin, often called Red Devil, and paclitaxel.
That's fascinating how they can predict the benefit like that. It really avoids overtreatment. Okay, that covers her likely plan. Let's quickly touch on a couple of special, more challenging situations. First, triple-negative breast cancer. You mentioned it briefly. What makes it so different?
Yeah, triple-negative breast cancer, TNBC, is defined by what it lacks. It tests negative for estrogen receptors, ER, progesterone receptors, PR, and HER2. Because it doesn't have these receptors, the targeted therapies we just discussed, anti-hormone therapy and anti-HR therapy, simply won't work. They have nothing to target. This generally makes TNBC more aggressive and harder to treat. The main weapon becomes chemotherapy. Drugs like doxorubicin and paclitaxel are standard. More recently, for some TNBC cases that express a protein called PDL1, immunotherapy drugs like pembrolizumab have shown promise when added to chemo, but it remains a challenging subtype.
Definitely sounds tougher without those targeted options. And what about the incredibly difficult scenario of being diagnosed with breast cancer while pregnant? How is that even managed?
That is an extremely complex and emotionally challenging situation, requiring a very specialized team. Treatment has to balance the mother's health with the safety of the developing fetus. Radiation therapy is almost always contraindicated during pregnancy because of the risk to the baby. Hormone therapies like tamoxifen and aromatase inhibitors are also out because they can cause birth defects. They're teratogenic. Surgery, however, like lumpectomy or even mastectomy, can often be performed safely, usually best during the second trimester. Chemotherapy is the trickiest part. Some chemo drugs can be given, but typically only starting in the second or, more often, the third trimester, as the risk to the fetus decreases later in pregnancy. The specific drugs and timing are very carefully chosen. It's incredibly difficult navigation.
Wow. It really highlights the need for expert multidisciplinary care in those cases. So pulling back from these specific cases, it feels like the constant theme, the most powerful message running through all of this is the value of prevention and especially early detection. What are the key takeaways for you, our listener, on that front?
Absolutely. If there's one thing to hammer home, it's that early detection is your single most powerful tool against breast cancer. And the cornerstone of that is screening mammograms. For women at average risk, the guidelines do vary slightly, which can be confusing. The American Cancer Society, ACS, generally recommends starting annual mammograms at age 45, continuing until 54, then switching to every 2 years from 55 onwards, as long as you're in good health. The U.S. Preventive Services Task Force, USPSTF, has slightly different recommendations, suggesting screening every 2 years, starting at age 50 and continuing until 75.
So it varies a bit.
It does. The most important thing is for you to talk with your doctor about your personal risk factors and preferences and decide together on the screening schedule that's right for you. But the key is, get screened regularly.
And what if someone isn't average risk? What if they know they're at higher risk due to family history or genetics? How does screening change?
For high-risk individuals, typically defined by risk assessment models showing a lifetime risk greater than 20%, or those with known gene mutations like DRCA screening, needs to be much more intensive. It usually starts much earlier, sometimes as young as 25 or 30. And it often involves alternating imaging tests. For example, having a screening mammogram and then 6 months later having a breast MRI and repeating that cycle annually. The MRI is better at finding cancers in dense breast tissue, which is common in younger women and those at high risk. That sounds much more proactive, Are there other preventative strategies for high-risk women besides just screening?
Yes, there are. One option is chemoprevention. For women at high risk, particularly if they are likely to develop ER-positive cancer, medications like tamoxifen or raloxifene or aromatase inhibitors post-menopause can be prescribed. These drugs work by blocking the effects of estrogen on breast tissue, significantly lowering the risk of developing breast cancer in the first place.
So medication to prevent it. Exactly. And then there's the most aggressive, but also most effective preventative measure: prophylactic surgery. For women with a very high genetic risk, like those carrying BRCA1 or BRCA2 mutations, undergoing a bilateral prophylactic mastectomy surgical removal of both breasts before cancer develops can reduce the risk of breast cancer by 90% or even more. Often this is combined with prophylactic bilateral salpingo-oophorectomy removal of ovaries and fallopian tubes, because these gene mutations also dramatically increase ovarian cancer risk, and removing the ovaries further reduces breast cancer risk by cutting off estrogen production. These are major life-altering decisions, obviously made based on individual risk and patient preference after extensive counseling.
Those are huge decisions indeed, but powerful options. Beyond the medical side, what about everyday life, the lifestyle choices we make? How much impact do they really have?
They have a significant impact. These are things everyone can work on. Maintaining a healthy body weight is really important, especially after menopause, because excess fat tissue produces estrogen. Limiting alcohol consumption is crucial. Remember that link between daily drinks and increased risk. Staying physically active has consistently been shown to lower risk. Aim for regular, moderate exercise. Being mindful of the risks versus benefits of postmenopausal hormone replacement therapy and using it for the shortest time at the lowest effective dose if needed. And, as we mentioned, breastfeeding, if possible, seems to offer some protective benefit. These lifestyle factors really do add up.
That's empowering to know those daily choices matter. Lastly, we talked about metastatic breast cancer being incurable, but you also stressed that doesn't mean untreatable or without hope. Can you expand on what managing metastatic disease looks like today?
Yeah, that's a critical point. While we don't currently have a cure for metastatic breast cancer, stage 4, the goal of treatment is to control the cancer for as long as possible, manage symptoms, and maintain or even improve the patient's quality of life. And we've gotten much better at this. Treatments often involve cycles of hormone therapy, if applicable, targeted therapies based on the cancer-specific markers like HER2-targeted drugs, chemotherapy, and sometimes radiation for specific symptomatic spots, like bone pain. And a huge part of it now is managing the side effects of these ongoing treatments. For example, chemotherapy-induced anemia, low red blood cell count, causing fatigue and weakness, used to really limit treatment. But now we have effective agents like darbepoetin alpha and iron supplements that can manage the anemia, allowing patients to tolerate treatment better, feel stronger, and live more fully while managing their disease. It's about extending both life and quality of life.
That's a much more hopeful perspective on managing advanced disease. Thank you.
Wow. Okay, we have covered a huge amount of ground today. From the absolute basics of what breast cancer is, the symptoms, the whole diagnostic journey, the incredibly personalized treatment plans now, even touching on those tougher cases, and the power of prevention.
Absolutely. And if there's just one single message, one pearl we hope you walk away with from this deep dive, it's this: early detection truly is your best, most powerful defense. Knowing your body, knowing what's normal for you, understanding your personal risk factors, and sticking to those screening guidelines, that's how you catch breast cancer when it's small, when it hasn't spread, and when it's most treatable. It makes all the difference.
And the really positive note to end on, the narrative that keeps getting stronger, is that research isn't stopping. Advancements in therapy are happening constantly. The outlook for people diagnosed with breast cancer today is dramatically better than it was even a decade ago, and it continues to improve. It really does. So as we wrap up, maybe just take a moment to think. We've gone from the science to the personal health decisions. What's one small, informed step you could take, starting today? Maybe it's scheduling that mammogram, talking to your family about health history, or encouraging someone you care about to do the same, based on what we've talked about. Your awareness and your actions, they really do matter.